Role and importance of pulse pressure and mean arterial pressure. Number 1477, VPT Sharp 038, December 24, 2025. Gerald C. EclaireMD Foundation. Category: Blood pressure and mortality vascular diseases. Preface: This article is not written as criticism of medicine or medical professionals. Modern medicine played a critical role in my survival after multiple, life-threatening events, including my recent stroke. The purpose of this article is personal. I am a patient. After my stroke, I realized that many of the most important lessons about my own survival came, not from the clinic, but from careful self-observation. 16 years of collecting over 4 million personal health data points, and reading more than 10,000. Published biomedical and physiological research papers. I did not discover new biology or invent new measurements. Pulse pressure, PP, and mean arterial pressure, MAP, are well known in medical literature, yet they are rarely explained to patients by clinician in plain language, or connected to daily decisions after major vascular events. One particular incident is worth mentioning here. Yesterday, I discovered that my wife's annual average pulse pressure in 2025 had been consistently above 50 millimeters of mercury. This realization deeply unsettled me, as it suggested a heightened risk of serious long-term consequences. My concern for her health became a powerful personal motivation for me to begin this investigation. This article documents what I have learned by connecting public research information, my own long-term PP and MAP data, my post-stroke recovery experience, and my background in mathematics, physics, engineering, and viscoplastopology thinking. I am not proposing a new treatment and I am not giving any medical advice. I am describing how I learned to understand my own body more clearly, recognize its mechanical warning signs earlier, and adjust my daily behavior in ways I hope will help me and my wife avoid further damage. If this perspective helps other patients observe themselves more carefully, ask better questions of themselves, or reduce unnecessary fear, then this article has achieved its purpose. This is a record of learning, not judgment. Introduction. Blood pressure is usually reduced to two numbers: systolic and diastolic pressure, SBP and DBP. These two numbers are useful, but they are incomplete. They describe pressure at two moments in time, not how blood flows continuously, not how vessels behave mechanically, and not how organs are supplied with oxygen and nutrients to organs between heartbeats. Both pulse pressure and mean arterial pressure describe something deeper. Pulse pressure, PP, reflects how hard each heartbeat strikes the vascular system, while mean arterial pressure, MAP, reflects whether organs are continuously fed through blood flow between heartbeats. Together, they describe vascular mechanics and flow physics, rather than isolated pressure readings. These two variables sit closer to the root causes of many mortality diseases, including cardiovascular disease, CVD, chronic kidney disease, CKD, retinopathy, neuropathy, stroke, and dementia risk. Explanation in plain English. PP is SBP, DBP. Mean arterial pressure equals systolic pressure, plus 2 times diastolic pressure divided by 3. Pulse pressure, PP, is defined as systolic pressure minus diastolic pressure. In simple terms, PP describes how hard each heartbeat hits the blood vessels. Each pulse becomes a mechanical shock that travels directly into small vessels in the brain, kidneys, and eyes. When pulse pressure is high, it usually means arteries are stiff and cannot cushion each heartbeat well. In plain English, pulse pressure tells you how hard each heartbeat is, slamming into aging, stiff blood vessels. Mean arterial pressure, MAP, is calculated as systolic pressure, plus twice the diastolic pressure, divided by 3. MAP represents the steady pressure that keeps blood flowing to organs between heartbeats. MAP is not about the hit, but about continuous blood flow that supplies oxygen and nutrients to the organs. Mean arterial pressure tells you whether the brain, heart, kidneys, nerves, and other organs are receiving enough oxygen and nutrients all the time. When it is too low, organs are starved. When it is too high, vessels remain under constant stress. In plain English, MAP tells you whether your organs are being fed properly. Together, pulse pressure is the hammer, and mean arterial pressure is the water supply. You can have a good water supply, but a dangerous hammer, or a gentle hammer but not enough water. Stroke risk rises when the hammer becomes too strong, even if the water supply appears adequate. This is why pulse pressure and mean arterial pressure together describe vascular health better than systolic and diastolic numbers alone. Physiological meaning. Pulse pressure directly reflects vascular stiffness, loss of elasticity, wave reflection, calcification, and mechanical aging of vessels. Mean arterial pressure reflects effective organ perfusion, oxygen delivery, and nutrient delivery to the brain, heart, kidneys, nerves, and other organs. These two markers are not secondary indicators. They reflect the fundamental state of blood vessel health and the underlying mechanisms that govern it. Why medicine rarely emphasizes PP and MAP. Modern medicine faces a real limitation. There are no medications that directly repair arterial stiffness, restore lost elasticity, or reverse calcification inside vessels. Drugs mainly work by changing body chemistry, often quickly and temporarily. Pulse pressure and mean arterial pressure do not describe chemistry. They reflect the physical condition of blood vessels, including stiffness, flexibility, and flow behavior, which change slowly over time. In short, drugs act on chemistry, while pulse pressure and mean arterial pressure reveal structure and physics. Doctors are trained to focus on guideline targets, drug-responsive variables, billable treatments, and legally defensible actions. Systolic pressure, SBP, diastolic pressure, DBP, LDL, heart rate, HR, and hemoglobin A1C fit that model. Pulse pressure, PP, and mean arterial pressure, MAP, do not. When a patient asks about PP and MAP, the clinician often faces an uncomfortable truth. These factors matter, but they cannot be directly fixed with available drugs or tools. Avoidance then replaces explanation. This is not ignorance, it is a systemic limitation. What cardiologists can and cannot do. Medications can lower systolic peaks to reduce rupture risk, lower diastolic extremes to reduce cardiac workload, slow heart rate to improve oxygen efficiency, reduce blood volume or vessel tension, prevent clot formation, and stabilize plaques. In short, hypertension medications reduce acute events and help delay catastrophes. They buy time, but they do not fix the underlying problem. What medications cannot do is often misunderstood. While they are effective at changing chemistry, they cannot repair or restore aged body materials. They cannot reverse calcium buildup in arteries, rebuild elastin, which is the body's soft and stretchy material, or reshape stiff vessels back into flexible ones. They also cannot undo decades of mechanical fatigue. When pulse pressure rises due to stiffness, medications may lower overall pressure, but they cannot truly normalize pulse pressure without affecting mean pressure at the same time. Drugs cannot reverse the effects of aging on body tissues. Metabolic pathway to stroke. A common modern pathway to stroke follows a slow and predictable course. It often begins with excess body weight, which leads to reduced insulin response and then type 2 diabetes, T2D. Over time, chronically high blood sugar and insulin levels in type 2 diabetes damage the inner lining of blood vessels. This is exactly what happened to me. This damage triggers long-lasting irritation. That gradually leads to calcium buildup, vascular calcification. As calcium accumulates, arteries lose flexibility and become stiff. Stiffer arteries increase pulse pressure, PP, and transmit stronger pressure waves into the brain's tiny vessels. Over time, these fragile vessels either rupture or become blocked, resulting in stroke. This sequence of events exactly matches the cause and result of my own hemorrhagic stroke in the Pontine region in June 2025. Aging itself is not the primary cause. Aging mainly acts as a time amplifier. Mechanical stiffness accumulates much faster under metabolic stress. This is why two people of the same age can have very different vascular health, depending on decades of glucose exposure, insulin burden, visceral fat, inflammation, blood pressure swings, and physical inactivity. Interpretation using combined fluid VMT, solid VMT, and geometric topology, viscoplast topology or VPT models. From a solid VMT perspective, stroke is a rupture event after long-term structural fatigue. From a fluid VMT perspective, disease progression is a continuous, fluid flow of energy and stress through blood vessels over time. Pulse pressure, PP, represents pulse energy, while mean arterial pressure, MAP, represents baseline flow support. Topology describes how close the system is to failure. By examining distances between stable states and rupture states, stiff vessels transmit energy faster and farther, and microvessels fail first. Stroke prevention therefore becomes strain rate management, rather than structural repair. Personal data interpretation. From August to December 2025, my average mean arterial pressure, MAP, remained stable at around 85 mm of mercury, with no prolonged hypotension or sustained hypertension, indicating adequate organ perfusion. During the same period, my average pulse pressure, PP, remained persistently elevated at about 45 mm of mercury, reflecting chronic vascular stiffness. The moderate correlation of 59% between the PP and MAP curves showed that pulse pressure is driven partly by pressure and partly by vascular structure. Even with excellent blood pressure control, my pulse pressure did not decrease, further lowering MAP only, increased dizziness and fatigue without meaningfully reducing PP. At this point, further medication only lowers blood pressure symptoms, but does not improve pulse pressure, PP, leaving patients like me without an effective treatment option. How to avoid stroke when stiffness cannot be reversed. You cannot reverse blood vessel stiffness. You can only manage blood pressure shocks. This requires reducing metabolic stress by stabilizing glucose, lowering visceral fat, controlling food portions, maintaining good sleep, engaging in moderate daily exercise, and avoiding blood pressure spikes. I have been doing all of these, with particular attention to controlling emotional stress, to prevent another episode of acute hypertension after my recent stroke. It also involves limiting pulse energy surges by avoiding emotional extremes, sudden exertion, sleep deprivation, dehydration, and prolonged fight or flight states. Mean arterial pressure, MAP, should remain stable, neither too low, nor highly fluctuating. Microcirculation is supported through adequate hydration, consistent sleep, and regular walking. This approach focuses on fatigue management, not repair. In summary, stiff blood vessels cannot absorb pressure shocks. Avoiding those shocks is essential for preserving life. Appendix, Personal PP and MAP Safety Rule. After my stroke, I realized that standard blood pressure targets were not sufficient for my situation. What mattered was not whether numbers looked normal, but how close my vascular system might be to another rupture. Over past 22 weeks, I have collected 2,250 blood pressure measurements, and identified my own mechanical baseline. Mean arterial pressure, MAP, around 85 mm of mercury indicated stable flow, while pulse pressure, PP, around 45 mm of mercury reflected my vascular structural stiffness. Sudden BP changes mattered more than absolute or averaged BP values. The most important rule I learned is that slope matters more than height. Sudden jumps are more dangerous than stable elevations. My protection now comes from behavior, not chasing numbers. After stroke, pulse pressure, PP, and mean arterial pressure, MAP, have become my real-time mechanical warning system. Conclusion: pulse pressure, PP, and mean arterial pressure, MAP, reveal vascular aging more truthfully than traditional blood pressure measurement numbers, such as SBP, DBP, HR. My PP and MAP values expose my overall vascular stiffness, flow efficiency, and proximity to failure. Medicine cannot directly repair these chronic conditions, which helps explain why they are often absent from routine discussion. Medications may buy time, but survival is preserved through lifestyle control and mechanical awareness. I was not confused. I understood that I must act early, before the situation worsens. Learning about pulse pressure, PP, and mean arterial pressure, MAP, brought me closer to causality, and gave me a sense of control rather than fear. Last Q&A. Question: PP and MAP cannot be fundamentally corrected by chemical medications alone. The only meaningful way to manage them is through long-term lifestyle control, and by avoiding mechanical shocks that stiff vessels can no longer absorb. But how is this done in practice, and what kind of lifestyle can still help these two markers, PP and MAP, at a late stage of life? Answer: this is an important question, and the answer must be realistic, especially later in life. At a late stage, PP and MAP are not improved by rebuilding blood vessels. That is no longer possible. What can still be improved is how much stress and shock the vessels experience each day. The goal is not repair, but damage control through shock reduction. Lifestyle influences PP and MAP in different ways. For pulse pressure, PP, the main focus is reducing shocks. Stiff vessels cannot absorb sudden force, which makes abrupt pressure spikes especially dangerous. Emotional explosions, sudden anger, fear, or shock, can be more harmful than steady effort. Rushed physical exertion carries risk, while slow and steady movement is protective. Poor sleep, dehydration, and long periods of tension all increase pulse impact. In this setting, a calm and regular rhythm of life matters more than intensity. For mean arterial pressure, MAP, the goal is stability rather than lowering. Organs depend on steady blood flow, so MAP should not be pushed too low or allowed to swing up and down. Regular sleep, consistent hydration, regular meals, and predictable daily routines help maintain stable flow. Skipping meals, poor sleep, dehydration, or overcorrecting blood pressure can destabilize MAP and reduce organ perfusion. Metabolic control remains important even late in life. Stable glucose reduces ongoing vessel irritation and slows further stiffening. Avoiding large sugar and food spikes matters more than chasing low averages. Reducing visceral fat lowers internal pressure load, while gentle daily walking improves circulation without creating mechanical shock. These changes do not reverse stiffness, but they can slow additional damage. The lifestyle that helps at a late stage of life is not aggressive. It is calm, regular, and predictable, favoring slow movement over bursts, emotional regulation over suppression or explosion, adequate sleep over endurance, and hydration over pushing limits. Awareness replaces denial. In plain engineering terms, stiff vessels must be protected the same way an old structure is protected. Vibration is reduced, sudden loads are avoided, fluid flow is kept steady, and stress is minimized on materials that can no longer flex. That is how PP and MAP are managed. When chemistry, medication, is no longer the main problem, and mechanical and physical limits have become the dominant concern. Disclaimer: this content is provided for educational reference only, and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely. but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and related materials belong to the author, Gerald C.